Bismillahirrahmanirrahim. In today's lecture, we will see the basic pharmacology of diuretic agents. So, first of all, when we have to study any drug effects, we need to classify drugs, as we have already seen in detail. Why do we classify, and how many types of classification or classifying drugs is there? So if we classify diuretic agents, we can classify therapeutically in different classes. Number one is the carbonic anhydrase inhibitors. So this classification is based on mechanism of action. So carbonic anhydrase, as the name shows, that it's an enzyme. So inhibitors, so these drugs inhibit carbonic anhydrase. So we will see in lateral slides that what happens when we inhibit carbonic anhydrase, how the diuretic action comes into play. So the members of this class are acetazolamide, ethoxazolamide, ethoxazolamide, methazolamide, and dichloromethylphenamide. While osmotic diuretics, as the name entails, they have to do some osmosis. These includes urea, glycerol, mannitol, isosorbide. Then loop diuretics, the most famous and the most important drug in this class is furosemide. Well, then potassium sparing diuretics, we have spironolactone, triamterene, amiloride, and plurinon. Then we have thiazide diuretics, chlorothiazide, hydrochlorothiazide, indapamide, and mirtazolone. So before going into detail, as I asked you guys earlier, that you have to emphasize on different parts of nephron and the ions that are being exchanged in those segments. So all of these drugs act on different segments. For example, as the name indicates, that loop diuretics are those diuretics which act on loop of HENLE. So that is why these are called loop diuretics. So how and why they will produce diuresis, and if you remember, diuresis is the increased urine volume. So first we have to see the normal physiology in order to understand the pharmacology of the drugs, because if we know the normal physiology, then we would be able to see how these will affect the normal physiology and ultimately the disease physiology, or whatever you can see, the pathology, and how these can exert these drugs can exert their action, how these drugs can cure disease, how these drugs can mitigate a disease. So in normal physiology, if you see the percentage of reabsorption, and if you remember the glomerular filtration was virtually everything gets glomerulary from the glomerular capillaries into the renal tubule. Then the substances we need are reabsorbed from the renal tubule, from the urine, back into the blood. For example, glucose, most of the glucose is reabsorbed in proximal, early part of proximal, then it's a late part of proximal. So usually virtually all of the glucose is reabsorbed in proximal convoluted tubule. So what other substances are being reabsorbed in proximal convoluted tubule? Almost 66% free sodium ion, only sodium. Then 85% sodium bicarbonate, 65% potassium, 60% water, 100% glucose, and 100% amino acids. So the percentage of these substances that get reabsorbed in glomerular from the glomerular filtrate into the proximal tubules. So the most important are sodium bicarbonate and NaCl because these are reabsorbed in the greatest quantity or the greatest percentage. So any diuretic that will block this reabsorption will be a powerful diuretic. So which diuretic blocks these sodium bicarbonate is? That is carbonic anhydrase inhibitor. And if you remember, the sodium bicarbonate or the bicarbonate ion is responsible for the maintenance or takes part in normal physiology in maintaining the normal blood pH, that is you can say 7.4 plus minus 0.5, 7.35 to 7. So for any drug we have to see its mechanism of action. So carbonic anhydrase inhibitors actually block carbonic anhydrase enzyme, and where this enzyme is located, this enzyme is located in proximal tubule. Epithelial cells. The proximal tubule is made up of epithelial cells, and cells have cytoplasm. So this is a zinc metalloenzyme. Metalloenzyme means it has a metal. Which metal? Zinc metal. So it is where it is found. It is found on the apical or the luminal side and the basolateral side. Referring back to my yesterday's lecture. So this is a type 4 carbonic anhydrase, and this is also present in the cytoplasm. So we can see its diagram, it's here. So this is the epithelial cell of the membrane. This is the lumen of the urine of the nephron. So anything that is present here will be going into the urine. So this is also called, that is why it is also called lumen urine. So this is interstitium, and after interstitium there is a blood vessel. So here this is carbonic anhydrase. This is present on the luminal side. The membrane bound, this is present inside the membrane. So this can, and this is also present in here the cytoplasm. So this enzyme can cause, here you can see the dissociation of carbonic acid into water and carbon dioxide. Then this water and carbon dioxide enter into the cytoplasm of the cell. This carbon dioxide and water are combined to form carbonic acid in the presence of carbonic anhydrase. So this again dissociates into hydrogen ion and bicarbonate ion. So where it started off, bicarbonate and hydrogen make up carbonic acid. Carbonic acid is dissociated or is converted into water and carbon dioxide. Then this enters into the cell, where in the presence of carbonic anhydrase this will again become carbonic acid. Then it will dissociate into hydrogen ion and bicarbonate ion. Then this bicarbonate ion will be transported back into the blood all the way. So this is how carbonic anhydrase has an important role in reabsorption of bicarbonate ion and excretion of and the secretion of hydrogen ion. So if we block this enzyme here, this, if we block this enzyme here, so this will not be transported into the cell, and here the carbon dioxide and water will not be able to form carbonic acid, and carbonic acid will not be able to dissociate into hydrogen and bicarbonate, and ultimately bicarbonate will not reabsorb back into the blood. So thereby, by blocking this carbonic anhydrase, the net effect is transport of that was the carbonic anhydrase. So this net transport of bicarbonate from the tubular lumen to the interstitial space, followed by movement of water, will be hindered, and they will be potently inhibit both the membrane bound and cytoplasmic form of the carbonic anhydrase, resulting in nearly complete abolition. Abolition means the reabsorption will be abolished. So, effects on urinary excretion. This slide will tell you what will be excreted out in urine once you administer carbonic anhydrase. And in carbonic anhydrase, we have different drugs like acetazolamide is the most important one. So inhibition of carbonic anhydrase is associated with a rapid rise in urinary bicarbonate ion. So bicarbonate ion will be, you can say, will be present in urine lumen. So at maximum tolerable dosage, 85% of bicarbonate reabsorption is inhibited. So clinical indications of carbonic anhydrase inhibitors. The clinical indications or the diseases in which carbonic anhydrase inhibitors are used. So in addition to nephron or epithelial cells of proximal convoluted tubule, this carbonic anhydrase is also present in ciliary muscles of the eye. So this has a role in maintaining the intraocular pressure. Intraocular pressure is important because the formation of the fluid will be extensive in glaucoma. So what happens in glaucoma? Increased intraocular pressure. So this is the major indication for carbonic anhydrase, because carbonic anhydrase has an important role in forming or maintaining intraocular pressure. So inhibition of carbonic anhydrase in ciliary muscles and decreasing intraocular pressure, glaucoma is a major indication for carbonic anhydrase inhibitors. Then the other indication is urinary alkalinization. To make the urine alkaline, so bicarbonate ion is important ion for alkalinizing any medium. So once these block carbonic anhydrase, so bicarbonate ion remains on this side. It doesn't go along the sodium with the sodium into the blood. So it remains here. So it alkalinizes the urine. So that process is called urinary alkalinization. Why it is important? We have referred back to our absorption topic. We have seen the ion trapping. So opposite, we have seen in opposite medium, in opposite pH medium, the drugs will be ionized. So once the carbonic anhydrase inhibitors increase the pH of urine, so substances that are relatively insoluble in acidic urine such as cysteine and uric acid can be excreted out of the body by alkalinizing the urine. So simply what happens, the uric acid or the slight acidic substances or weak acids will become ionized in the basic pH. So ultimately they will cause excretion of these substances. Then metabolic alkalosis is a disease of increased tissue bicarbonate concentration. So what happens in metabolic alkalosis? Bicarbonate ion is concentrated in blood. So this could be due to long-term loop or thiazide diuretic used in heart failure. So ultimately carbonic anhydrase inhibitors can be used. Saline is the sodium solution, sodium chloride solution, is not suitable for these patients as these are already suffering from heart failure. So sodium is not administered in heart patients. This can trigger. So acute mountain sickness is another indication. So what is mountain sickness? Weakness, dizziness, insomnia and nausea can occur in mountain travelers who rapidly ascend 3000 meters. 3000 meters you can relate to Lake Safal-Malook. That is around 3000 meters. So if you rapidly ascend means without acclimatization. The first goal is to acclimatize one's body so that the mountain travelers need to acclimatize according to the situation. They spend a bit of time on 2000 meters, then 2500 meters, then they should move on 3000 meters on day 2 or day 3. But if they rapidly ascend up to 3000 meters, they can develop this. Some of the travelers can develop certain symptoms, and those symptoms are weakness, dizziness, insomnia and nausea. So this is called acute mountain sickness, and acute mountain sickness can lead to can take severe forms as this. For example, pulmonary or cerebral edema, accumulation of fluid or water in cerebrum, increased intracranial pressure or in lungs. So this can cause death as well. So we need to decrease CSF formation by decreasing CSF and brain's pH. So ultimately brain's pH will be decreased. If bicarbonate ion is excreted out in the body, excreted out of the body, so it will raise the hydrogen ion in the blood. So ultimately the blood pH will drop down towards acidic side. So this can save or diminish acute mountain sickness symptoms. So toxicities, hyperchloremic metabolic acidosis, renal stones, potassium wasting, drowsiness and paresthesia. These are central nervous system. The paresthesia and drowsiness are central nervous system effect. So you can see here, this is chloride. The ones okay, here, hyperchloremic metabolic acidosis. Then renal stones can occur and potassium wasting. Here you can see this. Okay, then we have loop of Henle.